Mr. Chairman, ladies and gentlemen, good morning. Firstly, I'd like to thank the organizing committee and Sergio Alfieri specifically for giving me the privilege to be here. My subject is there evidence that lightweight and heavyweight meshes influence hernia surgery outcomes? I don't need to go into the details for the evidence for use of meshes for hernia repair. The point that meshes reduce hernia recurrence and persistent pain has been borne out by several publications. The European Hernia Trialist Collaboration published in 2002, and the MRC trial in 1999, and several papers from the Liechtenstein Institute. More recently, the debate has focused on lightweight and heavyweight meshes. I'll quote only two trials, although both have been presented in this conference. It seems lightweight meshes reduce chronic pain, but at the price of a higher recurrence rate. The first trial went on to a recurrence of 5%, although that was attributed only to one institution. In the second paper, the recurrence rate went up to 3.7%. Some would find it uneasy. The question is, what is a lightweight mesh? A few months ago, we invited the major manufacturers of prosthetic materials to come and tell us what is a lightweight mesh and what do they make of it. That included Ethicon, B-Braun, Bard, and others. None of them could define what is a lightweight mesh, although they have various products. To make our job simple, we devised this simple classification, which is based on handling of the mesh and the residual weight of the prosthetic material. Ultra lightweight, less than 25 grams, lightweight, 26 to 45 grams, medium weight, 46 to 65 grams, and heavyweight, more than 65. Actually, in the heavyweight group, most of the meshes are 80 to 105 grams. I couldn't find any mesh that weighs between 65 to 75 grams. Earl and Mark, a recent issue of Surgical Clinics of North America, they also publish their classification based on density and porosity of the material. Their classification is slightly different. They say ultra weight less than 35, heavyweight more than 90. The classifications have a merit. If you take the lightweight, then it is experimental evidence suggests that this scar formation is more like a net rather than a scar plate, which happens with the heavyweight meshes. I have a problem with this particular classification because meshes are available in the range of 80 to 105, and therefore I think heavyweight should be 80 or less than that. Therefore, I would stick to my classification in which the heavyweight is more than 65 grams. This is the meshes that we use in our institution, Vipro 2 and Ultra Pro, Prolin, or similar meshes in that range of weight. The second question, outcomes in hernia surgery. There's a huge range of publications starting from mortality, morbidity, and patient-based outcomes. We all know that outcomes of any surgical intervention is dependent on various factors. Experience of the surgeon, the type of the procedure, here the type of the mesh, and again the type of the patient. Patients with chronic pain syndromes, long-term analgesics, psychological problems have very different outcomes. To focus down this business of outcomes, I looked at the National Institute of Health and Clinical Excellence guidance published in 2004. Their first guidance was published in 2001, revised in 2004. It is due to be revised in 2010. Now, they have also looked at hernia surgery very carefully and critically. When it came to outcomes, they categorized them as primary and secondary outcomes. primary outcomes are hernia recurrence and persistent pain. If you look at hernia surgery, then these two outcomes must be looked at carefully before we go on to the secondary outcomes. Now, you may argue with some of the outcomes classified as secondary, but they say duration of operation, conversion, early complications, infections, visceral vascular injuries, and quality of life. They put quality of life as a secondary outcome, suggesting that this should be taken in light of the primary outcomes. For my presentation, I'll take the two primary outcomes, hernia recurrence and persistent pain, and physical activity in the early postoperative period. I also believe that hernia recurrence is now a different issue. The presence of mesh has altered the characteristics and outcomes of recurrent hernias in today's surgery. In Edinburgh, we perform about 750 groin hernia repairs a year. The currently two dominant techniques are the laparoscopic repair, totally extraperitoneal, and the open mesh repair, Liechtenstein style. Our preference, surgeon's preference, has changed over the years. In 1994, Bassini was the order of the day. 2/3 of the repairs were Bassini. Laparoscopic was just coming in. Liechtenstein had just started. And over these years, Liechtenstein became 70%, but then gradually fell to about 33%. The laparoscopic surgery has seen a gradual rise, and the last data from last year shows 2/3 of procedures being laparoscopic and only 1/3 open surgery. We started audit of lightweight meshes, as I have defined, and heavyweight meshes in January 2004. Our methodology is based primarily on Lothian Surgical Audit Database. It is a computerized database which started in 1990. We record all operations, general surgical, patient's features, their clinic letters, wherever they have been, anywhere in any hospital in Edinburgh. We defined recurrence as a recurrent hernia which may have been diagnosed in the clinic or has been repaired by any of the surgeons in the region. To collect the data, patients were telephoned by an investigator who was blind to the choice of the prosthetic mesh. If a patient complained of recurrence or a swelling, patient were examined in the clinic. So it is a selective examination. Additionally, we also interrogated the database to find if a patient has had an operation and has not been included in our list. I'll come to the first primary outcome, hernia recurrence. This is a paper published in February in Hernia, comparison of outcome of the two meshes after laparoscopic repair, purely clinical paper. This is a summary slide. 251 patients, recurrence rate 4.3%. Prolene mesh 2.82%. But note that in the Ultra Pro group, follow-up is only 14.5 months. In the heavyweight group, it is over 2 years. And yet, the recurrence here is 4.3%, here it is 2.82%. At the moment, there is no significant difference in statistical terms, but still it concerns us that 4.3% is probably not an acceptable rate of hernia recurrence.